with controlled detachable coils was developed in 1991. This technique has gradually overtaken the microsurgical clipping as a first line of management of ruptured aneurysm. In the light of ESAT trials, this study showed about 9.6 absolute risk reduction in favor of endovascular coiling. Endovascular treatment is associated with less invasiveness and lower morbidity compared to microsurgical clipping. However, recanalization is a major disadvantage of such technique. The most meaningful definition of recanalization is the recanalization of volume within the aneurysmal sac large enough to allow retreatment with either microsurgical clipping or endovascular means. Over time, about 25% of cerebral aneurysm treated with coil show reopening of the lumen. The reported recurrence rates ranges from 5 to 55% in some literature. The primary goal of treatment of ruptured aneurysm is to prevent rehemorrhage. However, rehemorrhage after treatment is still an issue. The ESAT trial demonstrates that there is about 4.9% rehemorrhage after endovascular treatment, and it was 1.2 after microsurgical clipping. Predisposing factor for recanalization. First, the rupture status. Some study shows that the recurrence rate is affected by the rupture status. This may be due to the conditions that the ruptured aneurysm sac could be disturbed coil distribution, and the surgeon might insert less coils to avoid intraoperative rupture caused by coil perforation. In this condition, lower backing density and disturbed coil distribution will contribute to recanalization of the sac. Second factor is the size of the aneurysm. Many studies have demonstrated that the aneurysm size is associated with recurrence. Patients with aneurysm diameter more than 10 millimeter are more likely to develop recanalization. This may be due to the larger aneurysm size has more irregular shape that make it difficult to perform dense filling. Also, intrasaccular thrombosis are more likely to occur in larger aneurysm. Another factor is the neck width. According to the previous reports, the neck width of the aneurysm is associated with recurrence. This might be due to difficulty to achieve dense filling in wide neck aneurysm. Also, wide neck aneurysm have more blood flow than narrow neck aneurysm. Therefore, the neck width is also found to be an independent risk factor for recurrence of intracranial aneurysm. Location of the aneurysm. The location of the aneurysm is another risk factor for recurrence. Posterior circulation aneurysm are more likely to develop recurrence. Also, the technique of management. Use of intracranial stent have been successfully used to treat wide neck aneurysm. The main function of stent is to avoid cold herniation in the parent artery. Stent can change intraaneurysmal hemodynamics, induce the intimal hyperplasia, eventually wrapped into the blood vessel, remodeling the parent artery. Many studies reported that aneurysmal recurrence was significantly lower in stent-assisted coiling compared to non-stent-assisted coiling. Literature review. Gromby-Roy et al. Showed that the incidence of recanalization was observed in 31% in ruptured aneurysm, and it was 25% in non-ruptured aneurysm. Zhang et al. Showed that the aneurysm size was significantly associated with recanalization. There is 4.5-fold increase in risk of recanalization with aneurysm size more than 10 millimeter. In this study, the recanalization was observed in 24% of small aneurysm and 42% of large aneurysm. Another study regarding the neck width of the aneurysm shows that the incidence of recanalization was 32% in wide neck aneurysm, and it was 25% in narrow neck aneurysm. And this study regarding also the neck width of the aneurysm shows that the incidence of recanalization was higher in wide neck aneurysm than narrow neck aneurysm. In this study, comparing the incidence of recanalization regarding the mean of treatment in simple coiling The incidence of recanalization was 18.6% compared to stent-assisted coiling, which was 12%. Also, the study shows that the incidence of recanalization with simple coiling was 41%, and then stent-assisted coiling it was 15.8%, and after flow diverter it was 7.1%. Our experience in our study, 89 patients with intracranial aneurysm was treated by endovascular embolization. All patients were treated at Nasser Institute Intervention Neuroradiology Department. Regarding the rupture status of the aneurysm, in our study, 80% of the patient was ruptured aneurysm and 19% was non-ruptured aneurysm. And this table shows the aneurysm characteristic in our study regarding the size, neck width, and the sac to neck ratio. In our study, about 91% were located in the anterior circulation, and 9% were located in the posterior circulation. And this diagram shows the location distribution of the aneurysm in our study. In our study, 63 patients were treated by simple coiling, and 8 patients treated by balloon-assisted coiling, and 15 patients treated by stent-assisted coiling, and 3 patients with flow diverter stents. At least 6 months follow-up with conventional angiogram was performed to assess recanalization and the need for re-embolization. During the follow-up period, about 24% of our patients had significant recanalization. In our study, recanalization rate in relation to rupture status, the incidence of recanalization in ruptured aneurysm was 25%, and in non-ruptured aneurysm it was only 17%. Incidence of recanalization in relation to the size of the aneurysm, small aneurysm with less than 10 millimeter has incidence of recanalization was 22%, and larger aneurysm was 37%. Recanalization observed in 20% of narrow neck aneurysm and 41% was wide neck aneurysm. Recanalization rate in relation to the technique used, with simple coiling the incidence of recanalization was 28%, with stent-assisted coiling it was 6.6%, with balloon-assisted coiling it was 25%, and no recanalization observed with flow diverter stent. Illustrative cases, 39 years old male presented with headache, neck stiffness, slight confusion, CT brain showed diffuse subarachnoid hemorrhage. Conventional angiography revealed pericallosal aneurysm measuring 3 millimeter with narrow neck with sac to neck ratio was 2. Decision was made to perform simple coiling. And here we can see diagnostic angiography show pericallosal aneurysm. Final control angiogram show total occlusion of the aneurysm. And here 12 months follow-up show no evidence of recanalization. Case 2, 40 years old male presented with headache, neck stiffness, slight confusion. Digital subtraction angiography revealed right pica aneurysm. It was 4 millimeter. Also, the decision was also to perform simple coiling. And it was possible control angiogram show complete occlusion of the aneurysm and with still patent pica. And here we can see the last coil. There was a loop which was seen protruding into the pica, but the pica is still patent. So anticoagulation was added to the patient. After recovery from the anesthesia, patient developed manifestation of lateral medullary syndrome. Here we can see a loop of the last coil is seen protruding into the pica, and 12 months follow-up show complete occlusion of the aneurysm, and the pica is also occluded, and the patient is still complaining from manifestation of lateral medullary syndrome. Case 3, 33 years of female presented with subarachnoid hemorrhage. Digital subtraction angiography revealed a wide neck superior cerebellar artery aneurysm 7 millimeter in diameter. So the decision was to perform stent-assisted coiling after the patient was prepared the night before the procedure by double antiplatelet. The aneurysmal sac was successfully catheterized, and the open cell still was successfully deployed across the aneurysmal neck. Control angiogram show total occlusion of the aneurysm, and 12 months follow-up show no evidence of recanalization. 18 years old female presented with headache. CT angiography revealed right A2 segment aneurysm. The patient was planned for elective stent-assisted coiling after being prepared by double antiplatelet 5 days before the intervention. Digital subtraction angiography revealed right A2 segment aneurysm, 7 mm in diameter, wide neck. Aneurysmal sac is catheterized, followed by deployment of braided stent, which start to embolize the aneurysm by coils. However, during coiling, the coiling macrocatheter was extruded outside the aneurysmal sac before complete embolization is obtained. Multiple trials were done to re-enter the aneurysm through the stent. However, it was not possible. Control angiogram showed non-complete embolization of the aneurysm. The procedure were terminated, hoping that the flow diversion effect of the braided stent may work, helping for complete embolization. 6 months follow-up showed non-complete embolization, and the antiplatelet was drawn, hoping it may help for complete occlusion. And we waited for 12 months. 12 months follow-up show non-complete embolization. Here we can see wide neck A2 segment aneurysm, and braided stent were deployed across the aneurysmal neck, and the aneurysmal sac is catheterized. Final control angiogram show non-complete occlusion of the aneurysm. Multiple trials to re-enter the aneurysmal sac was failed. The procedure was terminated, hoping that the flow diverter effect of the braided stent will help to complete occlusion.
Can we conclude, please, because we are running out of time? Can we conclude? We're running out of time. It's 2 minutes over. Okay. If you want to say any concluded conclusion?
No, I will present another case. No.
No conclusion?
No.
Okay. Thank you very much. Thank you.